Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And I have with us today Dr. Daniel Hofer, who is a family medicine and a palliative medicine physician. He specializes in community-based palliative medicine, and he's with the Sharp Healthcare System in San Diego, California. Dr. Hofer, the session is yours.
Thank you again, Larry. Very happy to be here. We're going to get to talk about one of my favorite subjects, which is delirium in the elderly. This presentation is simply to help us raise awareness of the significance of this problem and hopefully improve outcomes and management for our advanced elderly population. And I could sit here and suggest that all of you have had the experience, or if you haven't, you're going to, where you sent a patient to the hospital with the best of intentions, you sent them for a surgery, and they come out and they're just not cognitively intact the way they were before they went in. And this is the understanding of that process, because we are now dealing with an advanced geriatric population that we did not research in the past. And so if we're going to move forward, we don't want to just fix the organ system. We want to protect the things that are most important to our patients at this age. And one of those, in fact, usually the most important issue, is maintaining the patient's cognition. So I call this the what happened to grandma presentation, because the family comes in, or the grandchild comes in and said, yes, you got her over your pneumonia, and you fixed her hip, but she's not the same person she was prior to that hospitalization. I have multiple disclosures. I'm a consultant for multiple organizations, so they're listed there. It does not conflict with anything we're talking about today. So I'm going to give you a little quiz. This was a study looking at 425 hospital admissions, age 70. Always shocks me when I see those numbers because it seems so young these days. Although these patients were generally more frail. 1/4 of them, diagnosis was about 35% compared to about 21% without it. The 2-year mortality was almost 60%, 6 out of 10 patients, and without it was 42. The institutionalization rate for these patients at 2 years was 54%, twice that of patients without the diagnosis. And at 2 years, 90% of these patients are either dead or institutionalized. And they spent about a week longer in the hospital. The 3-year mortality rate for these patients in a different study put that at almost 80%. To put those numbers into perspective, those morbidity and mortality rates are as bad or worse than most cancers that we take care of, advanced cancers, or advanced stage 4 heart failure. What's the diagnosis? The diagnosis is delirium, hospital-induced delirium, an incredibly common problem that is not frequently diagnosed or managed appropriately. And we know that these abrupt declines in cognitive function are a tremendous prognostic concern, and we can also predict who's going to get this problem. They're associated with early mortality. And so we need to be aware that we're not putting a patient into a position where the mortality induced by the side effect of hospitalization is actually worse than fixing the problem we sent the patient to the hospital for. So I would agree with this comment. Clinicians have markedly underestimated the impact of brain dysfunction. We need to up our game in this area. It needs to become as important as checking vital signs and doing pre-hospital preoperative screenings, or just general care for the patient as they get older in your office, and use of medications or any other thing we would recommend for the patient. And just to drive the point home, hospital-induced delirium has a 1-year mortality that is exactly the same as a myocardial infarction or sepsis. So we need to up our game. We need to be aware of this diagnosis. So we're going to talk about the significance of delirium in this presentation. So we know that because delirium is iatrogenic in part, it's become a clinical quality indicator in the National Quality Metrics Measures Clearinghouse of the Healthcare Research and Quality Department has determined that the incidence of delirium to be a marker of quality of care and patient safety. The NIH recognizes what we should all know, is that delirium is the most common side effect of hospitalization for the elderly. And I want to repeat that. Delirium is the most common side effect of hospitalization for the elderly. And you can ask yourself right now on discharge summaries, or if you work in the hospital, how frequently are you making this diagnosis? It's more common than iatrogenic infections, pressure ulcers, DVTs. This is the most common side effect of hospitalization. The Institution of Medicine considers early detection of dementia one of its 6 goals to improve quality of care in the healthcare industry. And we're going to be talking about the association between delirium, particularly hospital-induced delirium, and dementia. Is this an expensive disease? Absolutely. If you look at the cost of diabetes, delirium is in that same range. Now think about how much you and your institutions do to manage delirium. Manage dementia. One more time. Think about what your institutions do to manage diabetes. And then ask yourself, do we do the same in trying to manage delirium? And most people would say, no, we don't. And we need to up our game in that area to improve our management of delirium because it is so consequential in outcomes for our patients. The problem, or part of the problem anyways, is that we refer to delirium by anything but its proper name. So we have names like acute brain failure, altered mental status, acute confusional state, toxic metabolic encephalopathy. You can think of some others. We need to start calling delirium by its name and properly defining it by the parameters that tell us how bad the delirium is and what type it is. Why is this important? I love this research article, and I wish I could put it on every one of my presentations, but I'm going to just present it here. This was a study that looked at the advanced elderly, and they asked them, what are your treatment preferences if you're seriously ill and you're an elderly patient? 74%, just about 75%, just about 90% of patients said that they would forego a treatment if the treatment burden was low, but there was a probability of severe functional or cognitive impairment. I mean, so they're saying that, yes, I know you can fix that problem, but if the consequence is functional or cognitive impairment, we're going to turn that down. And that compares to almost 100% of patients who said, of course, I will accept the procedure or intervention if there's no risk of cognitive or functional decline. And that's true for patients that still have physiologic and cognitive reserve, the younger and healthier population, the population that has historically been a part of research. But when we look at the advanced elderly, people starting to lose their physiologic and cognitive reserve, they're telling us, take a second look about what we think is important. The metrics you're using to define care are inadequate. We want to know about the cognitive and functional damage, even if you fix the organ system perfectly. I want to make one last comment about that too. Mortality was not those patients' biggest concern. It was quality of life, and that's the big question in improving quality of life. And the difficult part, of course, is that some people look at improving quality of life by fixing the organ system without even recognizing that there's other unintended consequences that could easily be predicted. So if we want to be up to date on this issue with delirium and management of the elderly, we need to recognize that the physiology and goals of care for the pre-terminal population and the advanced elderly are not the same as the younger and healthier geriatric patient, or frankly, any patient that we manage. How common is delirium? Extremely common in hospice, ICUs, nursing homes, hospitals. I've worked in all of these areas. It's very common with particular surgeries, hip repair, cardiovascular repair. It even occurs in cataract surgery. I showed you a previous presentation, 25% of TAVRs. God forbid I do this presentation and people say cataract surgery, people develop delirium. Now, most of the patients were older, but I would give this presentation about delirium and somebody would come up when I was doing this initially and say, that's exactly what happened to my dad. I had one medical director whose 92-year-old father was getting a cataract removed. He was confused and delirious afterwards. And after the presentation, he called up the ophthalmologist and canceled his father's second surgery because he said that if that happened again, they may as well not have their father anymore. Non-surgical omissions, very common. You can read about the prevalence and incidence. just so you know, if patients just had anesthesia, that's not, they get about 8 hours before we start to call them delirious. So we're changing the old paradigm, and this is the way I was educated in the 80s. Acute hospital delirium is a medical emergency with significant short-term but no long-term consequences. You cannot tell who might develop delirium, and what we know now is that acute hospital or outpatient delirium needs emergent evaluation, and it is absolutely associated with both short-term and long-term consequences, and that we can predict who is likely to develop delirium. This is to show you a prognostic model. There are many prognostic models. I keep this one in my back pocket. Any cognitive decline, poor vision, functional impairment, high comorbidities. In the hospital, if they get a restraint, you can prognosticate that this patient is likely to develop delirium. A high risk if they have 4 or 5 of these. How many patients do you take care of now that have cognitive, visual, functional, and high comorbidity impairment that are just sitting in your office? They're high risk, and their probability of developing hospital-induced delirium is 63%. Their risk of death or nursing home placement is 64% at a year. We know this before we send the patient to the surgeon or to the hospital. Is that a piece of information that your patient or family would want to know? Also important is the patient's age. And I'm going to talk about this in 2 ways. Number one, as our patients get older, at about the age of 70, there's just a straight line up in the risk of developing delirium if they're put in the ICU. So if you know you're sending a patient for an ICU procedure, you can almost guarantee they're going to get delirium and the consequences of delirium. I do want to talk about this because this little flat part of the graph, maybe a little bit back here down to about age 30 when you actually do have some improved physiology. This is where research is done. We excluded all these people on the up part of this line. And we excluded it deliberately because these people would skew the results for the flat part and this part over here on the left. We extrapolated our research here and said, well, it's equally applicable, and ignored the cognitive and functional and geriatric syndrome that define good outcomes. We can't do that anymore. We have the most rapidly growing demographics are in this group, and 19 to 20% of our population will be over the age of 65 in 15 years. We have to up our game in knowing how to manage this group and the consequences of our care. And this is just another example. As you get older, your risk of delirium is markedly higher. If you go to the ICU, ICU is a very intense insult. And so we need to be prepared to be thinking about this when we make a recommendation for a cardiac or other procedure that would put a patient in the ICU. We need to know that 40% of elderly patients who develop delirium never return to their previous cognitive function. And that's based on studies looking at this from 3 months to 5 years out. Just to look at this in a different way, this is a study that was done about 8 years ago, testing the hypothesis that hospitalization itself in the elderly was associated with subsequent cognitive decline. They had almost 2,000 patients in this study, followed for 12 years, evaluated every 3 years, and what did they find? For the group, pre-hospital, cognitive decline was at a rate of 0.031 units per year, and this was using a global hospital cognitive decline evaluation, different tool. Post-hospital, it was 0.075 units per year. That's an overall decline increase of 240% by using the hospital to manage the patient's disease. And it is an association, but it does tell us that perhaps it would be better if we manage these patients more aggressively, proactively, upstream and in the patient's own home or place of residence. Memory decline increased by 330%. So you can tell patients if they're going to the hospital for their care, they should expect their cognition and memory to decline. Executive function decreased by 170%, and this is why patients have a hard time following our directions. We need to be very careful, especially patients that are repeatedly hospitalized. It was worse if they were older, longer lengths of stay, and more severe illness. That's just not surprising, as you've heard from some of my previous lectures. Just to show you what that looks like graphically, these are patients who are managing their illnesses without using the hospital as a tool to manage disease. And these are patients who are being hospitalized, and you can see the more rapid decline in cognition over time. We do know that patients with dementia, I've talked about this before, are more likely to develop hospital-induced delirium. So anybody who has pre-existing cognitive decline, more likely to have delirium. That's about 66 to 89% of demented patients in the various studies. Delirium accounts for 40% of hospital days in hospitalized older patients. So this is an expensive extension of patients' lengths of stay in the hospital. This can be prognosticated and proactively managed, and that's why it's so important to know who's at risk. Just to show you with the subpopulation of patients, that not just all patients, but this is demented patients. We looked at this for demented patients when we saw the exact same problem with demented patients, that this is the normal decline for demented patients in the dashed line on the bottom. But when they started to use the hospital with delirium, these patients actually had an acceleration in the decline of their dementia post-hospitalization. So it does matter no matter who that subpopulation is. There's different forms of delirium. Hyperactive delirium is actually rare. That's the patient we hear about who had a hip repair and they're trying to get out of bed at night and they're fighting with the nurse. Mixed is more common. It's actually a combination of the patient being calm and hyperactive delirium. However, the most common form is hypoactive delirium, which is probably why delirium is missed so often. Hypoactive delirium, the patient's just calm and not hyperactive. They're a little bit lethargic or disoriented. They're not alert or attentive, and we're going to talk about that a little bit more. But know that there are different forms of delirium. If you look at the severity of delirium outcomes, no delirium, subsyndromal incident delirium. Subsyndromal means they don't have all of the symptoms of delirium. Incident means that it happened in the hospital or in the institution. Subsyndromal prevalent delirium, so they came in with it, but they didn't have all the symptoms. Incident delirium, prevalent delirium, and then the question is that just the pathway to dementia? I want to show you that you can use this tool to prognosticate. I spent 25 years working in nursing homes. Patients would come into the nursing home. Rarely did they have a proper diagnosis of delirium on the discharge summary. And frankly, doctors are worse than nurses at diagnosing delirium. It takes some effort to actually find out and evaluate whether the patients had delirium. But they would come in and I would read the nursing notes, and you could forewarn the patients that if the patient had hospital-induced delirium or had persistent delirium in the nursing home, they were 500% more likely to be dead at 6 months. It's a different trajectory. And if they had delirium, the ones that survived, these are the ones that became custodial. And equally, not quite equally as bad, is subsyndromal delirium. So I wouldn't be relieved that they didn't have overt delirium. It just means it's less severe, but it's telling you they don't have the cognitive reserve. That was a nursing home. What about the general population? This is a 3-year study looking at mortality with hospital-induced delirium in the advanced elderly. And if you go out to 3 years, that's about an 80% mortality at 3 years if a patient develops hospital-induced delirium. And that makes it tough because when a patient dies 2 years after the hospitalization over here on the left, it was actually directly related to the incident that induced the delirium that accelerated the geriatric syndrome and led to the patient's demise. You can see mortality rates. The control is no delirium on the top. The dashed dark line is hyperactive delirium followed by mixed delirium. Hypoactive delirium mortality rates are higher. It's the gray line on the bottom. The longer the patient has delirium, the worse the outcome. And the number of symptoms that resolve in the delirium diagnosis also prognosticates mortality and risk. So the worst case scenario for our patients is to have prevalent hypoactive delirium which persists with no resolution of any symptoms. It makes a matter. It matters. You don't just say the patient has delirium. You define how that delirium presented itself, and you can guide your patients and families in what to expect. So delirium is the susceptibility of the patient. They become more susceptible as they get older. It takes less of an insult to make them delirious, and it's also associated with the severity of the insult. The problem isn't that we're not developing less insulting procedures. It's that the patients are becoming more susceptible. And even minor procedures, minor interventions, cataract procedures, valvuloplasty, TAVRs, even overnight observations can induce delirium, and you can't take it back. So what's the pathophysiology of delirium? We know about this: the low blood oxygen, the low blood sugar, strokes, metabolic abnormalities, drugs, anesthesia. These are common causes. I think what we forget is about the aberrant stress response, the inflammation that induces delirium. Any inflammatory process can do that. And you have to ask yourself, why is it that my grandmother, when she had a UTI, became confused, but I've had a UTI or a cold and I don't have that problem? And that's because we can tolerate the inflammatory process. The cytokine-mediated inflammation causes cognitive changes that are expressing themselves in a way that as physicians, we can acknowledge some prognostic information to the patient and their family, even if they recover from that acute event. The other axis that's particularly concerning is the LHPA axis, and these are those patients you move from the ICU to the med-surg floor, and they become confused. You move them from the hospital to the skilled facility, they become confused, or even you move them from their own home to living with their family, and they become confused, or assisted living and board and care, and they deteriorate. We've all seen that, where a change of location has actually deteriorated the patient's cognition and functional ability, and that's their LHPA axis. If you look at the criteria for delirium, here's the actual criteria for the diagnosis: acute onset, fluctuating nature, inattention, disorganized thinking, altered level of consciousness, but that can be, quiet, stuporous, comatose, just being calm, not necessarily hyperactive, disoriented, memory impairment, perceptual disturbance, psychomotor agitation or retardation, and sleep-wake cycle disturbance. And this is always my favorite, sleep-wake cycle disturbance, because what's one thing you're guaranteed to get in the hospital? You will be imposed a sleep-wake cycle disturbance, because somebody's going to go in your room every 3 to 4 hours to check your blood pressure, your blood sugar, check your neurologic status, and it's very unlikely that you're going to get a good night's sleep. So what's the difference between the DSM-3R and the DSM-5? And all the DSM-5 adds is that these changes shouldn't be able to be explained better by another cause. Now, we don't expect a UTI to cause confusion in most people. We do expect anesthesia to cause confusion in most people, because that's the purpose of anesthesia, the sedation. So if you're trying to distinguish, you have to look for a cause, but is it a better explanation? And the answer is no, that patient is delirious. So here's the most common tool used to diagnose delirium, not only in the United States, but internationally. It's the confusion assessment model. Now, number 1 and 2 are mandatory, and then you have to have either 3 or 4. And it's a sudden onset in mental status change, fluctuating in nature. Do not perseverate about the fluctuation. It's not hour to hour. It can be over days. It can be over minutes. It can be variable, but don't worry so much about the fluctuation, just that they had a sudden onset and then it comes and goes. They have inattention, so difficulty focusing, they can't keep track. I would give a pearl to primary care providers. If you have a patient that comes out of the hospital that you used to be able to speak to directly, and you find yourself having to really explain to the patient or help them to focus, or you are turning to the patient's loved one or family members to talk to them about what happened, that patient may still have persistent hypoactive delirium, and that should raise a red flag, and you need to evaluate that. 1 and 2 are necessary. They will either have disorganized thinking or altered level of consciousness. They don't have to have both, just one or the other. That screening tool has a sensitivity and specificity over 90% for both of those. So some pearls about delirium is that it's missed about 68% of the time. The range in studies is from 50 to 85% of the time, and this is in hospitalized patients. frequently misdiagnosed as depression. You give these patients a PHQ-9, they're going to test positive for depression. They're actually having hypoactive delirium. Might be mistaken for dementia. We know that their MMSE drops when they have a delirium episode, and people diagnose that as dementia. You can't diagnose dementia when a patient is delirious or has an episode that could have precipitated delirium. Or people just say it's normal old age. Well, it is a part of the process, but it should require a medical action, an actionable item, that if you know the patient has delirium or you know that they're at risk of delirium. And it's very common at discharge in some research studies, up to as high as 32 to 60% of patients. One of the most important issues, I can't overemphasize this, you've heard me say this already, preventing delirium is the most useful strategy for reducing its frequency and complications. Once present, management of delirium has not been shown to improve long-term mortality or institutionalization. You can't take it back. Think of it as a global stroke. Your patients don't have the stem cell mediated cognitive reserve to get back to the way they were before, and so you can't get them into a state of recovery. So there's no returns. An old article, but it hasn't really changed much. Meds, infections, there's lots of metabolic processes, CHF, COPD, metabolic abnormalities. These are the things you need to be looking for. Iatrogenic in other ways, dehydration, immobilization. One of the worst things we can do to our geriatric patients is to put them to rest. You put them to rest, they may never recover function or cognitive ability. Any type of a restraint, not just a Posey restraint, but a Foley catheter, an IV, anything that keeps the patient from getting up and moving. Medications can be a restraint. Psychoactive medications which affect cognition. We talked about catheters, but we can pull that one out in particular because those are notorious for causing problems. Metabolic issues, malnutrition, since we're not paying enough attention to catch malnutrition early when there's something to do about it. Sleep deprivation, which have already pointed out the induced on our patients when they go to the hospital, and complications of diagnostic therapies or treatment of the patient. I remind people as well that delirium is directly related to the number of medicines prescribed and the number of drug-drug interactions. Anticholinergic medications are the most concerning, and we'll talk more about this in the next presentation. But I will emphasize that polypharmacy is something we must attack aggressively. Clinical guidelines are changing for the advanced elderly. We need to demedicate patients that should be demedicated. And I will give one example. For example, the American Geriatric Society has advised us that as patients get older, above the age of 75, the goal for hemoglobin A1C should be somewhere around 7 and 7.5 if you think they're going to have longer than 10 years, and 7.5 to 8 if you think they have less than 10 years. And that would help you demedicate your patients. Besides the fact, if you follow Beer's criteria, there's many medicines we shouldn't be using in the advanced elderly, because according to the Accord and other studies, hypoglycemia is highly intolerated in these demographics. The myocardial infarction risk goes up by 250%. The ADRs, hospital-induced hypoglycemic hospitalizations, goes up by 700%. And there's other adverse effects by over-medicating the elderly. So what are the physiologic processes that are causing this change? And the elderly and geriatric patient have tremendous changes going on. 40% decrease in hepatic blood flow, so they're not detoxifying the medication. Their kidneys are not clearing the medication as easily. There's less protein binding. But just think, you take the same medicine at the age of 90 that you were taking at 40, there's much more free medicine in that patient's system because we're not clearing it, we're not detoxifying it, and it's not being protein bound. It's actual free medicine. The same dose is markedly more powerful in an elderly patient. As well, there's altered body composition, so increased fat to water ratio, and they may have more permeability or distribution of those medicines may change. Increased cognitive sensitivity. The blood-brain barrier gets leaky. So medicines that didn't used to get in can get in, and there's less cholinergic neurons there. So anticholinergic medications in particular, they're highly potent medicines in the advanced elderly. Things that we may have taken or provided to our patients, they can become very harmful to these patients. and there's increased physiologic sensitivity. I always remind people, just because the MRI or CAT scan read normal brain for age, that doesn't mean you're done. These patients have age-related physiologic changes that we need to be aware of when we're prescribing or managing these patients. So when our patients develop delirium, there's multiple issues associated with this problem. These patients will have more hospital complications, greater ICU use, longer lengths of stay, institutionalization, readmissions go up, cost goes up, and they will have permanent functional and cognitive decline from baseline. So let's take a little closer look about that cognitive issue. This can go through the history of this. This is a study from 1994, progression and resolution of delirium in elderly patients that were hospitalized. Does delirium actually go away? The Harvard Delirium Project, about over 300 patients. A third developed delirium, although 96 had subsyndromal delirium symptoms at discharge. Only 28 of the 31% and 17 of the 96% showed complete resolution of their delirium symptoms at 3 and 6 months. Different study, 2003, so about 7 years later, 1, 2, 6, and 12 months, 34 patients with prevalent delirium, 91 with incident delirium. Demented patients at 12 months had a resolution of a total of 1 symptom. Non-demented patients had a resolution of slightly more than 1 symptom, but none of them completely resolved their delirium symptoms. And this is what that looks like graphically. And since it looks like it gets better, and we would say, well, it'll get better over time, it does, but it doesn't go away, and you catch them in a nadir because it's a fluctuating condition. You think they're actually back to normal, they're not, and then it starts to rise again about the end of a year. What are the symptoms we need to look at most? Well, inattention is very common, disorganized thinking, disorientation. These are symptoms that are very common, particularly in demented patients, but memory loss, look at that. That is almost certain to have some level of memory loss over time for patients that have had hospital-induced delirium, particularly in the advanced elderly. The next question is delirium the precursor for dementia, and here's a study 2006, so we're getting closer to 2020. No pre-existing cognitive hearing or visual deficits, known hip or knee replacement, mostly fractures, 25% were elective surgery. This was a 5-year prospective study. In patients that developed hospital-induced delirium, they were 10.5 times more likely to be diagnosed with dementia in the next 5 years. 10.5 times more likely to be diagnosed with dementia. Is that something that you would take as an actionable item to review the patient's medications, encourage them to protect their cognition, forewarn them about what happened and what it means? Here's a meta-analysis of research articles such as the one I just showed you. This is from 2010 out of JAMA. Hospital-induced delirium was shown to be associated with a 12.5 times greater risk of being diagnosed with dementia in a 4.1-year window. That's particularly high risk of developing dementia if you have had hospital-induced delirium. Now, we know this is an association, but there are so many research articles now connecting the association between having had delirium and developing dementia. That is something that I feel morally obligated to tell every single one of my patients, that this is the consequence of having developed hospital-induced delirium. These are some of the original research articles. If you want to go read them, that's fine. There are now hundreds of articles showing the association between delirium and cognitive damage. I think of delirium as actually chronic traumatic encephalopathy, the same issue we see in football players and athletes, where you can only take so many hits to the head, and then eventually you're going to have some downstream cognitive damage. Now, we don't know for each individual how much that will be and how many hits it takes, but we do know that it exists. And we do know that patients, as they get older, lose their stem cell mediated cognitive repair. So we have to be careful with how many times we put their brain under unnecessary stress. couple of more research articles, very important. High risk of cognitive and functional decline after postoperative delirium, 2008, 3-year prospective study. This was pre and post-op evaluations at 8 and 38 months. These were patients 60 years of age and older. That scares me because I am 2 years out from this. They were excluded if they had pre-existing dementia and pre-op delirium. 200 patients, 20% developed post-op delirium. Average age was about 74, very typical research article. Most of them were women. These were elective procedures primarily. Fractures in 28%, so the reverse of one of the previous articles. And what did it show? At 38 months, about 33%, 33 patients died. If the patient had delirium, they were 350%, 3.5 times more likely to be dead than if the patient did not have delirium. The association with functional impairment was that the patient was 500%. More than half of these patients would have some level of severe functional impairment after 3 years compared to people without delirium. And the cognitive impairment was devastating, 54% compared to 4%. If you forget everything else I said today, remember this. These patients come out of the hospital with delirium. You can't not diagnose this. You can't miss it. It tells us what's coming, and we need to be prepared for these patients because we're dealing with a much older demographic. So that's the data. That's the significance of delirium. I would encourage people to look for hospital-induced delirium, encourage your hospital colleagues, or if you work in the hospital, develop systems. We're going to talk about that more and how to prevent delirium and programs that are out there. They are telling you about the future of your patient, and take the time to sit down with your patients and family and warn them that because of this event or because you are at risk of this, maybe you want to think about how you want to live your life or whether you want to go through the procedure before you move forward. So thank you very much. I appreciate the opportunity once again to give you a little update on the significance of delirium and what happened to Grandma.